Good evening, all. Our ranks have thinned out a bit thanks to COVID-19. So we got some people who've tested positive, and they will be Zooming tonight. So if you see some empty seats about you, that's probably why. So you all deal with people who are ailing, and so Grace, can you hear me all right? You can? Good, okay. All right, now, where's Karis? She's supposed to Zoom. All right, well, we'll go ahead and get started. And if that helps. Oh, it helps a little. So, all right, I want to do a little bit of cleanup on pharmacokinetics in the aged. Then we'll circle back and look at peds, because pediatrics, you can't assume kids are small people. They're not when it comes to drugs. We'll see they've got differences. You have to really pay attention to those. And then we'll go to chapter 8, the eyes and the ears. Everyone get the handout by email? Yes? Okay. Did you bring it with you? Hold it up. Good. There. Okay, you brought it. All right. Just asking. Just asking. Little too excited down there. All right. Let's say start with a word of prayer, and then we'll begin. Father in heaven, thank you once again for this cold day. We pray for our colleagues who are not with us. Please help them to stay well, be well, and to be healed. For the rest of us, do help us to live smartly. But once again, Lord, our lives are in your hands. And now, Lord, we march forward with that assurance, knowing that you will guide us in the way we should go. Help us now learn tonight of you. In Jesus' name, amen. Okay, let's look at some pharmacokinetic and a few pharmacodynamic considerations in the agent. All right, so when it comes to absorption, okay, Karis, can you hear me all right? You can? Good, okay. These are the effects that, or rather the events that constitute pharmacokinetics. Each of these is affected in some way by aging. So absorption, remember, from the gut is an active process. There are a few events that are passive, for example, short chain fatty acids will be absorbed passively through membranes. Some of the shorter medium chain fatty acids can as well be absorbed passively. Virtually everything else is absorbed in an active fashion. So absorption does slow down with age. Also, the use of bowel medications, for example, if you have, let's say, irritable bowel syndrome, a drug that's very commonly prescribed is cycloamine, and that slows down the bowel. Also, if you have drugs that depend upon acid for absorption and you're using antacids, that's going to interfere with their absorption. What am I thinking of? I'm thinking of antibiotics. Your penicillins, for example, need acid to be absorbed. Also, if you're using things rich in calcium or magnesium, those will interfere with the tetracyclines, and in some cases, fluoroquinolones. And then other drugs too can be affected by the use of antacids or bowel medications, proton pump inhibitors, things like that. So even though absorption slows down while you age, the other thing that slows down is the motility of the bowel. Because of that, these two events are going to sort of equal each other out. So absorption, when it comes to aging, overall is not affected that much. But the biggie I want you guys to be aware of is this part here. Let me use my pen here. This part here, the use of antacids and or bowel medications. That's really important. So take your highlighter, highlight that. Make sure you ask about that. Maybe in their purse they have some Tums. Tums, of course, it's full of calcium. Well, Tums is calcium carbonate. That's going to neutralize stomach acid, and then the calcium may affect the absorption of certain drugs. What sorts of things you're going to ask them? Say they have some Tums in their purse, or you notice the guy's got a wad of Tums in his pocket or something. What are you going to ask them? How often do you take them? Very good. Another question you might want to ask is when do you take them? You take them at night, or do you take it during the day, or do you take it PRN, pro res nata, which is a Latin phrase that just means, oh, whenever I need it. Because if they take a lot of it, that should tell you something. They've probably got maybe an acid reflux problem or something like that. Something is not quite right. Parenteral dosing, if you can help it, should be avoided in geriatric populations. And here's why. First of all, intravenous administration can cause peak effects in elderly patients. Now, you may put that into consideration, and with your dosing, you may know how to deal with that. But usually when you do intravenous dosing, usually you get these big peaks in elderly patients, and they can react quite unpredictably at times. Yes, ma'am. The drug all of a sudden hits the circulation, and there's a lot of it all of a sudden, swamping receptors, and because the metabolism is slower, the amount of drug, they get a lot of drug, and it's not getting metabolized, and they're going to have toxicity effects maybe quickly. So you want to be careful about that. There's a nostrum in these slides. You're going to see it over and over again. It's with the age of population. You start low and go slow. It should be slowly, but it doesn't rhyme with low. So start low, that is, start at the lowest dose possible and increase the dose only slowly. Start low and go slow. Intramuscular administration can be quite painful in those with small muscle mass. Also, the absorption, because your circulation's slower, can be erratic. So IM dosing has its caveats as well. So parenteral dosing, if you can avoid it, sometimes you can't avoid it, just be aware of these types of caveats in the elderly population. You have less muscle mass as you get older. So if you are injecting into the muscle and the muscle is more marbled in the elderly and circulation is not as good, your absorption is going to be erratic. Instead of having the static type of absorption, your absorption may go haywire. And the patient may get a lot, be toxic one day, not have very much the next day, and then whatever. It's unpredictable. Distribution, you're really going to see a lot of changes with aging when it comes to distribution. So whereas absorption doesn't really show a lot of differences when it comes to aging, because the slower absorption and the slower motility tend to equal out, distribution, yeah, that changes a lot. So this is significantly affected by aging because your lean body mass decreases. There is a component in pharmacology we call volume of distribution, which has the incredibly unfortunate abbreviation of VD. Why do they name things like that? Okay, to me it's Valentine's Day, but in popular culture, VD does not mean Valentine's Day. It means venereal disease. So that's a lousy abbreviation, but hey, just roll with me on this one. Volume of distribution refers to the space in your body that the drug will occupy. So if the drug is water soluble, it will occupy plasma, it will occupy extracellular fluid like the lymph or other types of extracellular fluid. It will occupy intracellular fluid. It will occupy all those aqueous spaces. But you have other space, and that would be fat. And because your lean body mass decreases, and you have a relative increase in fat stores, even in thin individuals, you're going to have more partitioning of lipid-soluble drugs to fat stores. That means that if you give a lipid-soluble drug, its concentration in circulation might very well be poor because it'll be partitioned to the fat stores. So if this is the water storage site and this is the fat storage site, that's what you're dealing with in an elderly patient. In a younger patient who's nice, lean, mean fighting machine, this is going to be a lot smaller. In an elderly patient, even a thin one, it's going to be more this case. That represents a pharmacokinetic challenge. So this represents fat-soluble drugs. This represents water-soluble drugs. You can see that with repeated dosing, drugs can accumulate in fat, and the subsequent release of those drugs from the fat can be erratic. And you can get very unpredictable results from certain drugs in the elderly for that reason, particularly with things like psychotropics, because many of them are very lipid soluble. Remember, the half-life is dependent on the volume of distribution. So your lipophilic drugs will have a longer half-life in geriatric patients. That is one you can take to the bank. So how are you going to dose them then? You're going to dose them up or down? Down. Start low and go slowly. Pause right here. If there's any questions, make sure we're all on the same page. Oh, I had the most disheartening thing told me today, this morning. I paused, I said, anyone have any questions? And a student said, well, we don't understand a single word coming out of your mouth, so how can we ask you any questions? I wanted to leave the room and cry, but I just kept going. I hope that's not the case with you. Do you understand what I'm saying? Do you? Please say you do. Please, please, please. Scratch my ego. Tell me you're all right. Yes? Explain that. What if they all of a sudden, let's say they get sick and they lose a lot of weight? That weight they're losing is fat weight, isn't it? That can cause a massive release of the drug. Now you're going to have side effects that they didn't have before. Write this down. Write this down. Prepare to see side effects all of a sudden pop up in elderly patients, especially after they've been ill. This is the reason why. Don't be surprised by it. Expect it. Yeah, they may have released their concentration of the drug in the blood may be a lot higher. You may need to order blood work to measure the concentration of the drug. Or elderly patients, this happens occasionally, they forget to eat. This just happens. Some of you work in care homes. You've probably seen this, particularly with those who are suffering from dementia or my dad, God bless him, God rest his soul. Dad was a great guard. Dad was a farmer. Dad loved to make things grow. That dude had a thumb that was so green, you could use it as a stoplight. I'm serious. The guy could get anything to grow. Dad once went out and started working in his garden. And he said, oh, I'm going to trim these roses. Then I'm going to plant this, plant that, da 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 da, so on and so forth. Dad got so into what he was doing that we started at probably 9 o'clock. And then Dad didn't finish till it was 6 at night. He hadn't eaten all day because he got so infatuated with his garden and getting those roses planted and pulling this up and making sure the weeds were taken out and spraying for this and blah, 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 so on and so forth. He just got very, very involved and he didn't eat. And then he got really, really tired and weak. And it was like, okay, the guy was in his 80s, kind of some slack. And I said, Dad, I left this morning, you were working. What'd you have for lunch? I didn't see any dishes in the sink. He said, oh, I had lunch. You sure? What'd you have? Well, I had some of that roast. The roast is still there, and it was what it was like this morning. Oh, expletive. You're imagining things, so on and so forth, blah, blah, blah. Dad had forgotten to eat. Now, was Dad showing signs of dementia? No, my father was always eccentric. But eccentricities can be exaggerated as you get older, and that sort of thing can happen. And if they forget to eat, that can cause erratic release of drugs. Some of you, I'm sure, could tell stories like that with your grandparents or something like that, or maybe if you work in a care home, you can tell a story like that too. It's not that unusual. So just keep that in mind.
Dr. Baratovich?
Yes, go ahead, Grace.
Yes, I have a question. So for water-soluble drugs, can you explain how they're affected by aging. I got the whole lipid soluble, but not so much the water soluble.
Water soluble drugs are in terms of volume of distribution. So Grace asked, how will water soluble drugs be affected by the changes in volume of distribution in an elderly patient? They won't be affected that much. So if drug is water soluble, it'll be much more predictable, but its metabolism won't be as predictable, and that's what we're going to get to next. All right, so phase 1 enzymes. Your cytochrome P450s are significantly affected by normal aging. Their activity goes down. By the time you reach 65, your P450s are probably reduced like close to 30%. By the time you hit your 70s, 80s, they're reduced in some cases by half. Depends on the enzyme. It's also very individual. But these enzymes are affected by aging. They decrease as you age. That means that drugs that are subject to metabolism by cytochrome P450s will have longer half-lives in the aged. So you have to dose them down. Dose them down. Also, keep this in mind too, because elimination of the drug depends upon its metabolism. Very often its excretion will also be delayed because its metabolism is delayed. You see the problem here. Now, phase 2 reactions are not affected by aging. So these medications are the ones that are preferred in geriatrics. And the elderly also have reduced renal function typically. Something else to keep in mind. The most clinically relevant will be cytochrome P450 1A2 and 3A4. 3A4 definitely being the most clinically relevant because that has the most substrates, and that shows 3A4 shows pretty respectable decline as a result of aging. So aging affects the liver, and so clearance, particularly with drugs that are cleared by the liver, decreases, but it varies from person to person. And here's the hitch, bless you. Liver function tests don't correlate with how well you metabolize drugs. So you order an LTF panel, that's not going to tell you anything. So when in doubt, try to stick with drugs that are predominantly metabolized by phase 2 reactions. And if you don't know, ask your pharmacist. Write that down. Ask your pharmacist. He or she will know, and they will gladly tell you. And if they don't know, they can find out really quickly. You've got other things to worry about on the floor without paging through your phone while your other patient's heart monitor is going off. No, just ask the pharmacist. They'll find out for you. Your pharmacist is your friend. Utilize him or her. All right, so elimination, otherwise known as clearance. Most drugs will be eliminated in a concentration-dependent fashion. So the steady state plasma concentration will determine usually your rate of elimination. Now, there is a protein in your GI tract called the P-glycoprotein. What is the P-glycoprotein? P-glycoprotein is meant to pump poisons out of your cells. So your small intestinal cells take up a drug, they take up more drug, P-glycoprotein will pump it out. And some drugs block the P-glycoprotein. And if they block the P-glycoprotein, they can increase absorption and thereby increase concentration of the drug in the blood. P-glycoprotein activity goes down when you age. Because it goes down, that can increase steady state plasma concentration of some drugs and thereby increase the rate at which they are excreted. Not all drugs are substrates for P-glycoprotein, but a few are. Well, several are actually. We will note those as needed in this course. Remember, P-glycoprotein is not going to affect drugs that are given parenterally. It's going to affect drugs that are given orally.
Dr. Bradovich.
Yeah, go ahead, Grace.
So drugs, you just said drugs given parenterally don't block P-glycoprotein. Is that what you meant?
Well, some do, but they're not, their absorption won't be affected by P-glycoprotein because P-glycoprotein will affect absorption of drugs in the bowel if they're taken orally.
Okay. Got it.
Okay, so with aging, you get reduction of the heart, you get reduction of hepatic blood flow, reduction of renal clearance. Therefore, you get reduced clearance in general. Because you get reduced clearance in general, and because you may have increased concentrations if the drug is subject is a P-glycoprotein substrate, but your patient isn't pumping it out via P-glycoprotein, you have a tendency for greater therapeutic, but also greater toxic effects. So that means you may get the same therapeutic effect with a lower dose. And with a standard dose, you may get toxic effects. So I hope this reiterates the point that I'm making. You just offset this by reducing the dosing rate. Hence my start low and go slow rule. Unlike the liver, kidney function can be determined by measuring the glomerular filtration rate. That's fairly easy to do. You can do that with a blood test. So if you order a creatinine level, that can be used to estimate pretty nicely the glomerular filtration rate. That glomerular filtration rate will tell you essentially what the clearance rate will be for that drug. And if, yeah, go ahead.
Why is it so low for doctors to order one
Because of the dye you're given. To know essentially, some people, the dye, if it's in your body for a long time, can have pretty profound effects on nerves, on your eyes, on various parts of your body. The dye is meant to go in and then find its way, do its job, and then out it goes. If your kidneys don't work and the dye is going to stay in you for a lot longer, that's not good. So that's why you always do that pre-imaging. If you're going to use contrast dye, which for certain types of imaging, you have to use contrast dye. There's just no two ways about it. Now, there is an equation you can use if need be, and this equation can take into account the age of the patient, the patient's gender and ethnicity and serum creatinine. And there's always this little equation here that you can use. You have a half-life of the drug will be times this constant times the volume of distribution. There are tables you can get online to estimate that, and then divided by the clearance. So this essentially, you have these numbers that you can get with a blood test that you can calculate. That's a constant. Zaba boom, you know the half-life of the drug roughly. And this is a good place to start if you want to figure out a dosing rate essentially. Just keep in mind that as volume distribution goes up, half-life goes up. As clearance goes down, half-life goes up. So all these things are related. Yes? Oh, that's the equation for estimating GFR. It's online. Just type it in. You'll see it. Oops. So if you are treating someone, here essentially are your doses. So you dose them, and then after one dosing period, dose them again. Another dosing period, they take another dose, and then boom, here is your therapeutic concentration. So that means we have 1, 2, 3, 4. Usually going to take about 4 dosing periods before we get to our steady state. So about 4 to 5 half-lives to reach the steady state. That's a rule of thumb essentially for most drugs. Any questions about any or all of that? Again, start slow, start low, go slow. Start low, go slow. If you get nothing else out of this lecture, remember that little nostrum. Start low, go slow. What about pharmacodynamics? At least when it comes to psychotropic drugs, there will be greater effects in an elderly patient than you would get with a younger patient, even if you give that younger patient the same dose. So your elderly patient will be more sensitive to psychotropics. So you get, number one, greater sensitivity to the drug. That's usually due to the fact that the receptor, because there are fewer receptors, the sensitivity of the receptor to the drug in terms of signal transduction from that receptor is much higher in an elderly patient. Also, because of less circulation, you're going to have higher drug concentrations at those receptors. And then, of course, various baseline differences as well that'll make the patient more sensitive to various factors. So you have reduction in certain signal transduction at certain receptors, but you also have reduction in acetylcholinesterase. That means that your muscarinic receptors are going to have less breakdown of acetylcholine, so there's going to be more neurotransmitter around them. That means that these receptors will be very sensitive to anticholinergic effects. Therefore, any anticholinergic you give an elderly patient must be given with extreme caution. You have to tell the family and just tell them you may get psychiatric effects. You may get dementia, you may get sleep disturbances, you may get all these sorts of things. Anticholinergics, if you give them in the elderly, rather, if you can avoid them in the elderly, avoid them. Even small doses can be problematic. Diphenhydramine, that's not a drug we think of as being an anticholinergic, but it has anticholinergic properties. So even something like diphenhydramine given for a sneeze, for a runny nose, or to sleep actually can cause very profound dementia, sleep disturbance, behavioral disruption, so on and so forth in the elderly. Okay, key points, take homes. Question, yes, go ahead. Anticholinergic means it blocks receptors that normally bind acetylcholine. We're going to look at several drugs that are used in control of the bladder and also drugs for the GI tract that are anticholinergics. Some of these cross blood-brain barriers, some of them don't. Anticholinergics across the blood-brain barrier in the elderly can have very profound behavioral effects in the elderly, and you want to avoid them. Remember that example I gave you last week about donepezil and oxybutynin? That's an example of an anticholinergic and its profound effect in the elderly. All right, take home number one. Normal aging does not affect phase 2 reactions, the most prominent of which is glycuronidation. But it does affect oxidation, that is phase 1 reactions that are cytochrome P450 mediated. So medications metabolized via phase 2 reactions are preferred in the elderly. And if you don't know, who's your friend? Your pharmacist. Thank you. Every hospital has one, so go ask them. Start low and go slowly. That's the rule. By reducing the dosing rate, you can counteract the effects of reduced drug clearance in the elderly. Can't stress that enough. 3, there are greater psychotropic effects in the elderly. You have greater drug sensitivity, you have higher CNS concentrations, and also baseline differences, and avoid anticholinergics if you can help it. Are there any questions? Okay. Now let's talk about children. Absorption in children can be very, very unpredictable. So you have weak gastric acid production in children. That's going to tend to increase the bioavailability of drugs that are acid labile. It will decrease the bioavailability of weak acid drugs. So for example, a weak acid drug like phenobarbital. In children, you're going to have decreased bioavailability of such a drug because of weak stomach acid. Whereas you'll have higher bioavailability of acid labile drugs. You also have reduced bile salt formation. So your absorption of fat-soluble drugs can be decreased. Drugs like, for example, diazepam. Another name for diazepam is Valium. That would be an example of a fat-soluble drug. You have reduced gastric emptying and reduced intestinal motility. That increases the time it takes to reach therapeutic concentrations. And this is particularly the case in infants that are younger than 3 months. After 3 months, it starts to improve. Usually, by the time the child reaches the toddler stages, those sorts of things have largely fixed themselves. In young infants, drug metabolizing enzymes are at high levels in the intestine. That's going to reduce absorption of certain drugs. The other feature that can affect drug absorption is the intestinal microflora. We talked about intestinal microflora in micro last semester. So you've heard of this, but because this is not stable in a youngster, this can affect absorption. How will it affect absorption? It'll be variable. So in children, particularly very young children, you can have reduced absorption. Injected drugs can be quite variable in the way they're absorbed. You have variable muscle mass in kids. If the child is ill, that can compromise circulatory status of the muscle. Also, the variability of the depth of the injection can affect absorption. If you inject drugs into children, it's best to use water-soluble drugs because they don't precipitate at the injection site. Transdermal absorption is extremely effective in children because the stratum corneum, the top layer of the skin, is very thin. So at typical doses, they may get too much drug too quickly when it comes to transdermal absorption. Also, the ratio of surface area to weight is much greater than for older children and adults. That's the other thing to consider for kids. Transrectal administration should not be used in children. Depending upon where the drug is placed, you'll get different absorption. And young infants will probably poop out the drug before it can do any good. What does work quite well in kids are inhaled drugs. Inhaled drugs. Pulmonary surface area is very good in children. It depends upon the reliability of the delivery device or the technique of the caregiver for that matter. Let's talk about distribution in kids. So a premature baby, about 80% of the volume of their body is water. So their volume of distribution for soluble drugs is huge, huge. They have probably about 6% fat in a premature baby. Full-term baby will be about 70% water and about 13% fat. Then that percentage of water decreases as the child ages. So an adult has about 60% water. And as the child ages, 1 year, 2 years, 3 years, that amount of water will gradually decrease. And the fat content will go up from 13 to 18%. But at 1 year old, babies will make more fat usually. And that is for insulation purposes. And the healthy baby, the chubby cheeks and all that, that's what that is. So about 1 year of age, there'll be about 22 or so % fat. And then that will decrease in the next few years and so on and so forth. If your drug binds serum proteins, you get less serum protein binding in kids because in kids, the albumin is handling bilirubin. So there's fewer sites for drugs to bind, so you're going to get higher levels than if the drug is a protein binder. So if the drug is a protein binder, you dose it down in kids. Because of the metabolism of the child is slower and comes online gradually, some drugs can have plasma half-lives 2 to 3 times longer than you'd have in adults. So phase 1 activity is very reduced in neonates. It will increase progressively through the first 6 months of life. In the first few years, after 6 months, the rates of liver oxidation of drugs will actually exceed the rate of adults. Then it slows during adolescence and gets to the adult rates by late puberty. Phase 2, maturation, will vary drug by drug, unfortunately. Maturation of the enzymes involved in phase 2 reactions tend to be delayed. But some drugs are phase 2 metabolized even when the baby's first born. So it varies from drug to drug. After the first 2 years of life, renal function is pretty much what you'd expect for an adult. But renal plasma flow is pretty low at birth. But it'll reach adult levels usually, as we said, about 2 years. Some it'll even reach adult levels earlier. Okay, so dosing in children younger than 12 years of age will be a function usually of age, body weight, or both. Age or body weight or both. And there are tables that will essentially tell you how to dose certain drugs. Some drugs you just might have to stay away from. Okay, it's time to take a break. Unless anyone has any questions. Our Zoom folk, any questions?
I have one unrelated, but related towards our pharmacist interview.
Yeah,
So the pharmacist that I interviewed didn't. Okay, so I have allopurinol as my drug,
uh-huh,
but the pharmacist I interviewed is a pharmacist at the University of Washington, where they get mostly oncology patients.
uh-huh,
So he sees that drug mostly used for oncology patients, but
uh-huh.
I didn't know if in my speech if I should talk about that or if I should look up other options to see if it's more widely used for gout more so than chemo. Does that make sense?
No, typically cancer patients, because of so-called tumor lysis syndrome,
Yeah.
the tumor will tend to release a lot of uric acid. Well, scratch. It'll release a lot of purines that are then metabolized to uric acid. So you get hyperuricemia, and
Okay.
that can precipitate a gout event, even in patients who've never had gout, or in patients who aren't even prone to gout. So allopurinol is good for that, but it's also good in non-cancer patients who suffer from gout.
Okay. But I just didn't know if I needed to do excess research or just
No,
solely based on what he
no.
gives me. Okay.
no, it's common, very commonly used. It's allopurinol, right?
Yeah.
Yeah, no, very commonly used for gout. So,
Okay. Perfect.
okay,
That's my only question.
okay. So, she's not here. Dinner. Stir fry? No. Stir fry's good. Go. Well done. No, darn. Yeah, I know. Okay, this is Emily's.
Well, I have a question.
Yeah.
The online quiz, I tried to do chapter 6, like redo it. And there was like 2 questions. I put in the right answer and it still told me it was wrong. Like I swear it was right. But no, like I tried.
I think I might need to redo that one again.
I'm sorry.
You know, somebody else emailed me They took it once and they gave him an answer. Then they took it again. They gave him a different answer for the same question.
Oh, and then it's right?
Yeah, it's just good gravy, people.
I know. I don't know what was wrong. I didn't want to try it again and like waste another try.
I just, man alive.
We can't.
No, it's just so 6. I'll take a look at 6 and
And then are the old grades gonna get taken out of Blackboard?
old grades.
Because I done the original chapter 4.
Yeah, I just need to delete them.
Okay,
I think delete them. Oh goodness. JMJ is.
Jesus, Mary, Joseph.
Oh, okay. I remember somebody put that on there. I can remember. Okay.
Yeah, I went to a Catholic high school, so we had pictures, and they would do it on their exams, and so then I started doing it on ours.
Oh, okay. Okay. So,
Yeah.
yes, okay, there. I got it right. Okay.
You just tell her to go for the form.
That's you, right?
No.
Oh, okay. You're Sydney. Wrong Sydney. Wrong Sydney. Okay. You're Andrea.
It's okay, someone at our phone floor takes that.
I still don't get names straight, and I'm terrible.
Dark hair, dark eyes.
Yeah, well, way it goes. Okay.
But they should have a report sheet and your passport.
Kara, it's great. Did you guys get the handouts I emailed? Did you guys get the handouts I emailed? On I here, we're gonna cover those next. So get those out. All right, let's resume. Yes, my feeling exactly. All right. Eyes and ears. So drugs for the eyes will include drugs for glaucoma. This is the PowerPoint that's online. Did I do something wrong? No? 8? I'm doing 8. So sue me. All right, so the drugs for the eye will be drugs for glaucoma and drugs for age-related macular degeneration and bacterial conjunctivitis, or it could also be for bacterial blepharitis, that'd be infection of the eyelid, or viral conjunctival keratitis, or potentially allergic conjunctivitis. Those would be the main features that we're going to cover today with respect to the eye. So glaucoma is a progressive optic neuropathy, and it is associated usually with increased intraocular pressure of the eye. This increased pressure is going to cause deformation of the eyeball. It then is going to stretch the optic nerve, and it's going to cause damage to the optic nerve. Remember, the optic nerve consists of axons of those ganglion cells that are in the retina. Yes, I'm taxing you all the way back to A&P. And the stretching can, remember, those axons are bundled together. You stretch them, you're going to damage them. You damage them, the ganglion cells may start to die, so your vision then will start to blur, and it may blur irreversibly. This increased pressure in the eye is due either to decreased outflux of the fluid, the aqueous humor, or increased outflow. Either one of those, or even both, can cause glaucoma. So the drugs that are used to treat glaucoma will try to decrease outflow, decrease inflow into the eye, or increase outflow from the eye. Why don't I say that again? The drugs to treat glaucoma, because it's due to increased pressure, increased fluid in the eye, will aim to either decrease the flow of fluid into the eye or increase the flow of fluid from the eye to out of the eye. I see some of you nodding at least. I think I really cocked that up the first time. All right. So the first set of drugs on your list should be the prostaglandin analogs. Prostaglandin analogs. Who can tell me what a prostaglandin is? Bueller. Prostaglandin is a fatty acid derivative that is taken and cyclized. It's taken and cyclized. And it's a very powerful signaling molecule. Prostaglandin analogs are administered topically to the eye. They are typically the first drugs of choice for glaucoma. Excuse me, for open angle glaucoma. Open angle glaucoma. These increase outflow of fluid from the eye. They will decrease the intraocular pressure, 25 to 30% or so. Notice that these drugs typically end with P-R-O-S-T, Prost. Yes, ma'am. They're going to decrease fluid coming into the eye or increase fluid going out of the eye. Increase flow out of the eye. You dose them once a day, usually at night. That makes them very convenient. Generally, they're very well tolerated. So bimatoprost or bimatoprost, lantoprost, lantoprostine, tafloprost, and tavaprost. Those are your ocular prostaglandins that are used for glaucoma. Generally, these drugs are well tolerated. They have few, if any, systemic effects. They can cause conjunctival hyperemia. What's that mean? Very close. Bloodshot eyes. Bloodshot eyes. Long-term use, they can cause darkening of the retina, and that's not reversible. They also may increase the length, thickness, and darkness of eyelashes, which some people have said they wouldn't mind. They can cause some local irritation, maybe some itching, maybe some dryness. You might get some blurred vision. You might also get atrophy of the subcutaneous fat around the eye, causing the eye to look a little more shrunken. That's with long-term use. You have some very, very rare side effects there. They happen very infrequently. These drugs in general do a very good job, and they are well tolerated. So let's see. Let me give you the cost of some of these. This would be for, this is a cost for about a month's supply, I think. So bimatoprost for a month's supply is about 200 bucks. That one is still under license, so it's more expensive. Latanoprost, the name brand is 200 bucks, but the generic is $12. That's not going to break the bank usually. Latanoprostine, which is still under label, that's 190 bucks. So is tafloprost. That's also under license still, under label. That's $213. Tavaprost is $183.90. So out of those, latanoprost is, the generic is your cheapest. Rest of them are a little on the expensive side. Questions about those drugs? Nope. Next come the ocular beta blockers. Beta blockers. We'll look at beta blockers. when we talk about antihypertensives. These are ocular preparations for the eye. These decrease aqueous humor production. Aqueous humor production. They block the beta 1 adrenergic receptor in the trabecular matrix that decreases production of fluid. So they decrease fluid production. These will reduce intraocular pressure 20 to 25%. You dose these either once or twice a day. So still pretty convenient. The beauty of these drugs is that they're usually very cheap. Usually these drugs are well tolerated. They may cause stinging, itching, redness, or even blurred vision. Some people may get fatigue, dizziness, bradycardia, respiratory depression. Those are systemic effects of beta blockers. Given the dose with these drugs and the lack of systemic absorption, these systemic effects are quite rare. But use them in caution with people with chronic obstructive pulmonary disease for that reason. Generic Timolol, a month's supply is $4. Cheap as chips. For that reason, it's very often one of the drugs that's gone to if people don't have insurance. Very cheap, well tolerated, and it works. Next, yes. They're eye drops. Yes. Beta blockers that are antihypertensives will be tablets that you will take. There's also IV versions of that for emergencies or something like that. And the different ones are listed there. You can see them. Cartilol, levobutanol, metoprolol, timolol, blah, blah, blah. Notice they all end in laughing out loud. But, you know, I remember this, glaucoma is no laughing matter. But these drugs are laughing out loud. Okay, it's stupid, but if it helps you remember it, sometimes you remember what's stupid, right? Next come the carbonic anhydrase inhibitors. These also lower production of aqueous humor. These, depending on the drug, can lower intraocular pressure anywhere from 30 to 50%. So notice these drugs will tend to end in zolamide. Zolamide. So there's dorzolamide, brinzolamide, acetazolamide, methazolamide. You get the picture. These will tend to sometimes cause stinging and redness in the eye. The eyes can get dry with these, and you can get blurred vision. On the average, though, these drugs are pretty well tolerated. These drugs usually have sulfur in them, but because you're putting them in the eyes and the eye is sequestered from the rest of the immune system, even people with sulfur allergies can still use them. And they are less expensive than the prostaglandins, but a tad more expensive than the beta blockers. So they're kind of middle of the road, shall we say. Then you have the alpha agonists. Alpha agonists. These also decrease aqueous humor production. These all end in onidine. Onidine. So brimonidine, apraclonidine, and what have you. These will reduce intraocular pressures by 15 to 20%. These are used usually after laser procedures to lower intraocular pressure after laser procedures. Now, these were thought to be not very well tolerated. Turns out the preservative in them, benzalkonium chloride, was causing most of the stinging in the eyes. Once you take out benzalkonium chloride, now the drug is much better tolerated. So these are actually fairly well tolerated. You do get some systemic effects with lowered blood pressure and fatigue and so on and so forth, but not very much. And this particular group of drugs, as you can see, contraindicated in infants and children. Now, this next drug inhibits the Rho kinase. The Rho kinase. So this will increase outflow of the aqueous humor. This drug is very new. It is as good as a beta blocker. It's very, very expensive. So this is not your first go-to drug because it's so new. And about half the people who took it got red eyes. And then 20% got this corneal verticulate. Golden brown, gray whorl pattern in the cornea. Once you discontinued it, that went away. Then there were other adverse effects. That, by the way, is what AE stands for, adverse effects. You can read about them there. Then we have your cholinergic agents. These will cause an increase in the outflow and decreased aqueous humor production. So these kind of hit both. Question? Natarsadil. If you have trouble responding to other drugs, you try this one as a last resort, because only then will the insurance company pay for it. This drug is a month supply of Natarsadil is $300. So it ain't cheap. You'd use it as a last resort, essentially. Nothing else works. Let's try this. Okay, so ocular pilocarpine. It will decrease intraocular pressure substantially. But you can get ciliary spasm and your eyebrow can really start to ache because of that. Also, you can get blurred vision, and the cornea can sometimes take a beating. So you never want to use this drug long term. You only want to use it short term. Systemic effects have been reported, but they're not at all common. Finally, marijuana will decrease intraocular pressures, but it's very short-lived. And marijuana has lots of side effects. So as I put in the handout, don't go there. Tell your patients, please, don't go there. There are much better agents that are much better tolerated that don't require you to get stoned in order to treat your glaucoma. There you have it. You heard it here first. Okay, any questions about drugs for glaucoma? How do you measure intraocular pressure? Anybody know? No. Tono pen? You guys ever seen a tono pen? Do they have a tono pen over across the street? No? It's oh, it's not this big. It looks kind of like a little gun. You it's got a little nipple, very small nipple. You put liquid on the eye, and then you take the toner pen and you just touch it, and it uses the surface tension of the liquid to measure the pressure inside the eye. It's a cool little device. The physics on it is really cool. You can actually buy them online at Amazon. I don't recommend that, by the way. I just think the physics behind them is just really cool. Anyway, I got my eyes checked in January, first week of January, and the optician, she numbed me up and she came in, and then she came in. I said, "Oh, that's a toner pen." She said, "Yeah, this is really cool. I just got it." She started to show it to me. The thing is, that dye they put in your eyes really irritates the crap out of your eyes. And she's trying to show it to me. I'm trying to see, and my eyes are watering like that. Anyway, it was all blurry. So she said, "Oh yeah, I should probably use this before you." Yeah. Anyway, so yeah, toner pens. Sorry. Not a very good look at it, but they're not very big. Not this big. They look like a tiny gun. And emergency rooms often will have them because people will get their head whacked, may have pressure issues. And so emergency rooms, if any of you work emergency medicine, you may use a toner pen on patients who come in. Ask Mindy if they have one across the street. I bet there is one over there. But they're really cool. They're easy to use too. Very easy to use. I think that's in order to see the cornea better because the liquid on the cornea can obscure things like corneal edema and things like that. That's what I think the air is. Or to see if there's cobblestoning of the cornea. That's what you get with corneal edema. Or to clear debris from your eyelashes or something like that. It's probably because the cornea, if you're looking at the cornea and you're looking for abrasions, it can be hard to see. And a puff of air will usually dry that out so you can see it much better. Yeah, Haley, go ahead. Metal thing that jabs your eye. Yes, on the, yeah, that's for, yeah. That's like a toner, but it's not portable, obviously. Toner pens you can carry around. No, that's, the Center for Sight does that. Center for Sight has a little, you know. Yeah. Yeah, no, it's a. All right. Getting back on track. All right, so age-related macular degeneration is the death of the photoreceptors in the macula. So you get these holes in your vision, usually in your macula where your vision should be the best. You get these holes and you're having to, you know, do this and stuff like that to read. And the area that is dyed, you get blood vessels that move into that area. And those blood vessels can then branch out across the eye. You need to drive them back. And so what's used are these antibodies against VEGF. VEGF stands for vascular endothelial growth factor. If you inhibit VEGF, you'll prevent the formation of those rogue blood vessels. Vascular, I'll write it on the board. These injections, you go through the lens into the retina and you give the drug, you lay the drug underneath the retina. Takes a lot of skill to do this. Ophthalmologist. These treatments are extremely expensive. They work though, they work really well. So they're given with topical anesthesia. And as I say, they are bloody expensive. Let me give you a taste of how expensive these are. So the cheapest one is the bevacizumab. Bevacizumab goes by the trade name of Avastin. That one for a single use is $50. Aflibercept is $2,000 a shot. Yep. Brolucizumab is $2,000 a shot. Ranibizumab is $1,200 a shot. Boy, discount. And pegaptinib is $800 a shot. You usually have to get them done every other month. Yeah. Then you get blood vessels forming in the area where the photoreceptors have died. The photoreceptors actively inhibit the formation of new blood vessels. When they die, now these blood vessels will actually invade that area, but they don't just invade that area, they invade other areas and they decrease your acuity of vision. So you're trying to fight them back.
So you would just continuously get these.
You have to continuously get these shots, yeah. So you have a risk of retinal detachment, which should make sense since the drug is being deposited intravitreally. Oh, and mind you, these are for wet macular degeneration. They're not for dry macular degeneration. Fortunately, wet macular degeneration is the most common. The pathology is the difference. All right, the rest is there. You have your wrist there, and then there's the photodynamic therapy where you use this verteporfin, and that will kill the endothelial cells of the neovascular tissue. You infuse it into the neovascular tissue, and then you just hit it with a laser, and the neovascular tissue goes kaput. Because the verteporfin reacts with the laser and kills the cells, which is kind of cool. But that one doesn't require a needle being stuck through your lens into the retina. Ugh. Sorry? This, by the way, is a medical letter that they have lots of good info, and that usually talks about pricing too. Oh, the drug itself is not that expensive. I'll bet you the treatment is, though. You know, I don't know. Maybe I should call my eye doctor and see, find out. Pharmacists may not know about the laser treatment. Marty Patriots probably would, though. Okay, we will finish this Wednesday, and then we'll go on to chapter 9, which is skin. Skin.
Are we still doing chapter 7 then? Just like a later time?
7 is the vitamins and
Or 7 is all the antivirals and like antibiotics.
we'll circle back to that one.
Okay. just wondering. Thank you.
Yeah. I didn't get to you. I was